Okay, good afternoon everyone and welcome to our members webinar. My name is Shan and I'll be hosting the webinar this afternoon for you. Thank you to everyone for joining in today. Your membership is very valuable to us and it's appreciated. Hopefully you're all logged in okay and can hear me. This month we're going to throw open our 1-hour webinar to all pituitary conditions. We are aware that our members have limited time with their endocrinologist, so this is an opportunity to ask any questions. Any questions are welcome and will be anonymous. Type your questions into the chat box and press send. Please be aware that you won't see it appear straight away because we are moderating the questions so that no one will see your name. Professor John Newell-Price will try his best to answer as many questions as we can in the time we have allocated. You may notice that the font in your chat box is a little small, so to make it bigger, you can go to the top right-hand corner of the box and click on the little icon for options, which looks like a circle. If you click on that, this will allow you to change the size. Try and keep your questions as short as possible so that John can understand the key areas that you want answers about. The webinar will also be recorded so that you can watch it again at a later date. So today we have a general question and answer session, and Professor John Newell-Price, endocrinologist, has kindly volunteered his time to answer your questions. He is Professor of Endocrinology at the University of Sheffield, Chairman of the Pituitary Foundation Medical Committee, and Research Lead for the Clinical Reference Group for Specialist Endocrinology within NHS England. So welcome, John. It's nice to have you here today. We'll get started now with the first question. I'll be reading them out as we go along. So the first one we've got here is, I had an adrenectomy 18 months ago, and to date, my remaining adrenal gland shows no sign of recovery. I have been advised to reduce my hydrocortisone from 20 to 15 milligrams per day to see if my adrenal gland will start working. What chance is there of this happening? I am struggling to maintain any sort of a normal life, so I'm continually fatigued. Will this improve?
Okay, well, good afternoon, everyone. I hope that you can all hear me. Please let the team know if it's not clear. So for the first question, I'm assuming that the person who's written the question has had an adrenalectomy for Cushing's caused by a single adrenal adenoma. So this is not anything to do directly with the pituitary, but of course Cushing's and steroids are very much part of the things that patients with pituitary disease are familiar with. So when there is a cause of any sort of Cushing's, what happens is the normal pituitary, if you like, goes to sleep for a variable period of time. And actually, it's not infrequent for the pituitary and the whole pituitary adrenal axis and the secretion of the hormone cortisol to remain low for at least a year and sometimes 18 months and sometimes longer than that. Extremely occasionally, even after someone's had an operation like in this question, the normal pituitary and the other remaining normal adrenal don't wake up at all, but that's very, very unusual. So in answer to the question, the best way to encourage your own body's production of cortisol, and that's allowing the pituitary to wake up and the other gland then to wake up, is, as you've been advised, to reduce your dose of hydrocortisone. And it's the later evening doses, particularly of hydrocortisone, which will tend to keep the production of your own bodies of cortisol lower. So we usually suggest that patients reduce from, for example, 10 milligrams of hydrocortisone in the morning, 5 milligrams of hydrocortisone at lunchtime, and 5 milligrams in the evening or around 6 o'clock. We usually advise patients to stop taking their evening dose. They're just taking the 10 and the 5. Sometimes moving the 5 o'clock, the 5 milligram dose from lunchtime to part the way through the afternoon to say 2 or 3 o'clock in the afternoon. The difficulty is that when you have your dose reduced, sometimes you may not feel quite as well, and you're in this sort of slight catch-22 whereby you're trying to reduce the dose to allow your own body's cortisol to recover, but that takes time. What is the chance of this happening? I'd be optimistic. It's very unusual. It is the minority, tiny minority of patients whose normal pituitary doesn't wake up at all. And to a certain extent, whilst people go through this process, you may struggle, but hopefully, as the other adrenal gland starts working, as your own body starts producing its own cortisol, hopefully that will improve. It's important to remember that if you are on any other steroids, so for example, if you take any inhaled steroids or steroids that are used in your nose for problem with rhinitis, or any topical steroids, then that can also limit the recovery of the normal production of cortisol. So it'd be important to see whether or not you're taking inhalers for asthma or other things that could be doing that. So in summary, I'd be optimistic that the other adrenal gland will start working. It may yet take more time, even though it's been 18 months. And unfortunately, it can be a process where you may not feel as well. And I would hope that once the other gland has woken up, that the fatigue aspect should diminish. I hope that answers the question.
Okay, brilliant. Thank you. So for the second question, I was diagnosed with empty seller syndrome and secondary adrenal insufficiency 2 years ago, and as time goes on, I am having terrible problems with sweating. I can barely walk across the room and the sweat is pumping out of my head. Is this to do with the illness or the hydrocortisone?
Okay, so the first thing to say is that empty seller syndrome is an appearance on an MRI scan. And there are many, many people who have that appearance who have completely normal pituitary function. However, if that is seen and patients have symptoms and it's then assessed and there is problems with the pituitary, of course, it's important that they get the appropriate replacement therapy. In answer to this question, secondary adrenal insufficiency means that the pituitary is not driving the production of cortisol from the adrenal glands. But this does not have anything to do with sweating, nor does hydrocortisone have any impact on sweating. So I'm sorry to hear there's this problem with the sweating. I'm afraid it won't have a cause related to either the empty seller or the hydrocortisone.
Okay. So for the third question, I have had Sheehan syndrome for 44 years. Genotrophin made a big difference to my lifestyle. I'm now 67. Will I continue as I am now, or will Sheehan's make life more difficult, and will I get more challenges as I get older?
Okay, so Sheehan syndrome, for the other people on the line, is when someone who is pregnant then has a bad bleed at the time they deliver their baby. And because the pituitary has a very good blood supply during the pregnancy, with a large bleed, this is when I bleed, I mean a bleed from having the baby, the blood pressure lowers, and as a consequence, the pituitary can then effectively sort of die off. And so you're left with someone who doesn't have a functioning pituitary gland. And usually, if that is that severe, patients with Sheehan syndrome Sheehan's was the person who described it, they then need all of the normal pituitary hormones to be replaced. The questioner here is asking about genotropin, which is growth hormone, and please, it's made a big difference to their lives. If they're 67 and well with genotropin, there's no reason to discontinue it, and I presume that they're on other anterior pituitary replacement hormones as well. So if they are well now at 67, there's no reason to stop the genotropin or other growth hormone therapies, and hopefully they'll continue to be well.
Okay, thank you. So for the next one, a slightly shorter one. For a panhypopituitarism patient, what does normal look like?
Okay, so I think that's a very good question, because normal clearly will vary entirely from patient to patient. My guess is the reason why this question has been asked, I'm guessing, is that the inquirer doesn't feel how they want to feel, i.e., what can they expect to get to on the replacement therapies that are available in 2017. And the answer to that is it's variable. We see many patients who are on anterior pituitary replacement therapy, including all of the different hormones the pituitary makes, and they feel very well indeed, and they feel really effectively as normal as they can be. Unfortunately, I'm sure many people on the line will recognize that that isn't always the case, and many people will feel either fatigue, lack of energy, and other problems. What we do from the endocrinologist's perspective is try and listen to what your problems are and try and adjust the therapies as well as we can. The problem we have is that however carefully we adjust things, it's never as good as the normal pituitary when it's working without any problems. And so in terms of what can you expect to get to, I think the answer to that would be once you have been on as optimized pituitary therapy as is possible, and that's been that for 6 to 12 months, you're probably reaching the stage where that's as normal as you would be and as normal as you would be for those pituitary replacement therapies. That is, of course, presupposing that the therapies have been carefully considered, your lifestyle has been carefully considered, and everything's been adjusted as well as it can do. It may take a bit longer. So I would say between 6 to 18 months of being on a carefully adjusted pituitary replacement therapy, that's probably going to get you to where you are likely to be. And in some people, that will be really good, and some people, unfortunately, despite everyone's best efforts, that'll be not as good as you necessarily want. Of course, it's important to consider whether there are other reasons why people may not feel fully well. So these need to be considered, and that's a discussion to be having with your endocrinologist or your endocrinologist specialist.
Great, okay, thank you. For the next one, can epilepsy be triggered either as a short or long-term result of pituitary surgery and or pituitary radiotherapy? And how often does this occur in pituitary patients?
Okay, so the pituitary is not a common cause of epilepsy. If the pituitary is large enough to push against some of the brain, then there is a potential to cause epileptic fits. And particularly if it pushes to the side, it can push into an area of the brain called the temporal lobe, and that can very occasionally cause epilepsy. The surgery itself would not usually do this unless it was very extensive surgery, and particularly if the surgery has been by the transsphenoidal route, i.e. up through the nose and across the transsphenoidal route. When patients have to have what we call a craniotomy, so there needs to be a cut in the skull to access the pituitary tumour, and that is occasionally necessary, much less so nowadays than previously. Simply by having what we call a craniotomy, there is a risk of developing epilepsy after that. And then finally, in terms of radiotherapy, radiotherapy itself is very unlikely indeed to cause epilepsy, particularly with the modern radiotherapy that's given. Some of the radiotherapy that was given many, many years ago could cause scarring, again, particularly in the areas called the temporal lobes, which are the side of the brain in the same horizontal plane as the pituitary, but really that would be very uncommon. So by and large, epilepsy is an unusual association with pituitary disease, but there are times when it can occur.
Great, okay, so the next one for you, are there any pituitary conditions or medication that has the effect of causing the patient to smell?
I'm going to interpret this by causing the patient to have a bad smell. I presume that's what this is meaning, rather than not being able to smell. I'll deal with both. So there are no pituitary conditions which actually cause someone to smell, or if you like, have body odor. If someone is hypopituitary, so for example, if you've got a man who is lacking pituitary function to drive testosterone, typically they will have less body odor than when they were normal with testosterone. So sometimes when you give men back testosterone, it can cause their body odor to become more apparent. And particularly that needs to be emphasized to younger teenagers when you need to do that to talk them through the potential impacts of that. If the question was about not being able to smell rather than having a smell, well, there are conditions which are called Kalman syndrome, where you don't develop the normal part of the smell apparatus in the brain That means you don't actually smell, and that's also associated with hypopituitarism as well. And that's a genetically driven condition, a variety of different genes that cause that. But that's a different question. That's someone who may present with hypopituitarism and an inability to smell. The pituitary gland normally looks normal, but because the pituitary isn't being driven from higher up in the brain, the patient doesn't develop hormones. So that's kind of smell and no smell. I hope that answers that question.
Yeah, brilliant, thank you. So for the next one, is there any evidence to connect sleep apnea with pituitary adenoma?
Okay, so that's another very good question. It depends on the pituitary adenoma. The most clear association is in patients who have acromegaly. So that's a growth hormone secreting tumor of the pituitary. There is a very clear association with obstructive sleep apnea in those patients. So that is something which needs to be asked about and at times needs to be investigated with sleep studies and things like that. So if someone, particularly with acromegaly, is developing falling asleep during the day, or their partner notices they're snoring a lot, that's something certain to consider that could be a sleep apnea. Other pituitary tumours, I think there's little evidence to make a direct association between sleep apnea and the pituitary tumour itself.
Okay. Great. So for the next one, is there any research currently being undertaken regarding the impact of pituitary conditions, the impact the pituitary conditions have on patients' mental health? I've had Cushing's disease, and although my physical symptoms are always listened to and treated, I've never been asked about my mental health.
Okay, and so in answer to the question, there's lots of research that has been done and is being done on the impact on patients' quality of life and psychological effects of pituitary conditions. And it is different between patients, obviously, but it's also different between the causes of their pituitary tumor. So we know that all patients, if you take all patients with pituitary disease, there is an impact in some of them on their mental health and quality of life well-being. If you take the different groups of pituitary patients, so the patients who, for example, have non-functioning pituitary tumours versus acromegaly versus patients who have had Cushing's, of those different groups, as a group, patients with Cushing's have the greatest impact on their mental health, quality of life. And the reason for this appears to be the devastating effect that the very high level of cortisol has on the brain function. So, for example, there have been very carefully documented studies where not only have quality of questionnaires been performed on all those three different patient groups, and patients with Cushing's come out worse than that. In addition, there are careful MRI scans have been done where you can actually look at the brain structure. And on those scans, patients with Cushing's have some shrinkage of parts of their brain, which even when you look 5 years after their Cushing's has been cured or put into remission, there are still some changes occurring. So that tells us that the impact can be very long-standing on patients with Cushing's. And so our usual message to patients with Cushing's is that there can be psychological effects which last and continue to have an effect for a very, very long time, even though the physical effects may have improved. And of all the problems that patients with Cushing's have, it's these psychological and mental health issues that really can be very tricky to get over and can last a very long time. And so, yes, there is work that's been done on that. Yes, it's a very important part of the assessment when discussing this issues with patients with Cushing's, but it's also quite a tricky thing. It needs to be carefully thought through, and if necessary, at times, the question of whether there is psychological support, or if there's a very severe, clear depression associated with Cushing's, which there can be, then it may be necessary to involve psychiatrists and further discussions with the person with Cushing's who's experiencing that. So in terms of whether there's more work being done, yes, around in different institutions there are pieces of work being done, particularly trying to validate various questionnaires that are used to assess patients with different pituitary conditions. So there are specific quality of life questionnaires for patients with acromegaly, specific quality of life questionnaires for people with Cushing's, specific quality of life questionnaires for patients with growth hormone deficiency. That's not related directly to mental health, as been asked here, but it is in terms of trying to assess the impact that these conditions have on general quality of life, which includes mental health functioning, in addition just to the physical effects. So I hope that answers the question.
Okay, great, thank you. Just to say as well, and for anyone that may have joined us a little bit late, thank you for all the questions you're sending in so far. We've had lots and lots. If you can keep them kind of as short, as simple for John as you can, just so that he can answer them, more concisely and kind of what answer you want, that would be brilliant. So the next question we're on to is, what can you tell me about the long-term neurological impact of pituitary tumours?
So I think we just covered quite a lot of that in the previous question. If the neurological impact, by that the inquiry is meaning to do with cognitive function, i.e. how you can think or not think so clearly, there's lots of work that's been done, and it is the case that people who have hypopituitarism and needing pituitary replacement therapy as a group, not everyone, tend to find that they can have some impairment in their cognitive function. And then again, as I mentioned in the last question, or the answer to the last question, it is patients with Cushing's where this can be more persistent. I think that's I hope answered the question about neurological impact on pituitary tumours.
Yeah, brilliant. Okay.
If neurological means that if it hasn't really answered the question, perhaps the inquirer could ask it again.
Yeah, brilliant. Okay. Just to say as well, some people probably are asking similar questions, but just worded in different ways. So sorry if we are repeating ourselves, but I think John's doing his best to cover everything. So a bit of a different one here. We've got acromegaly patient, had a second stroke, mainly affecting the throat, so breathing, eating and swallowing, but now in a lot less pain, and my acute tiredness has improved. Do you have any thoughts on this?
I'm not sure I think if I understand the question correctly, after the stroke, there's been some problems, but in a sense, there are other problems which have resolved. I think that's what I'm being asked here.
Yes, I think so.
So I guess it's a question of what other treatment the patient with acromegaly is on, and whether that's been adjusted, or whether indeed the control of the acromegaly has been affected, and what the various other hormonal treatments have been. If they are all absolutely the same and nothing else has changed apart from the fact that the inquirer has had a stroke, then I'm at a bit of a loss to explain the improvement of acute tiredness, but I'm pleased that's better. Of course, I'm sure it's not better for them for the neurological impact they've had on the breathing and eating and swallowing, etc. I can't explain the pain unless, of course, some of the pain fibers which have been affected by the strokes. I can imagine that it would be possible for someone to be experiencing less pain simply because the sensation and pain fiber sensation has been reduced by having had the stroke. I can't really explain the acute tiredness or improvement in that unless something else has changed. And of course, if there has been a stroke, I guess a question would be, where was the stroke? The strokes vary a bit, and if it's affected the swallowing, it sounds like it's in a particular part of the brain which is relatively low down. I guess it would be possible that there may have been some impact on the blood supply to the pituitary tumor causing the acromegaly, but I think that's less likely. So I can't fully explain all of the question. And I think it's most likely to be explained in terms of the pain by some impact on the pain fibers. Sorry,
Yeah,
I think I'd need more details, need to look at the scans and actually sit down and talk in quite a lot of depth to that particular inquiry.
Yeah, of course. No, that's brilliant anyway. Thank you. So if we move on to the next one, can you tell me the symptoms of having a low and high prolactin level, please?
Okay, I should probably deal with the hyperlactin first because that's much more common. So prolactin is made by cells in the pituitary gland called the lactotrophs. There's a variety of different cells in the pituitary gland, but that's the ones that it comes from. Normally, what happens is that the prolactin is necessary for the production of milk. And so when women have babies, you need the prolactin to have milk. If you have too much prolactin, then that can cause milk to be produced in women and men when there's no pregnancy. So that's one important symptom. Another important symptom is when prolactin is high, it interferes with the normal regulation of the hormones which drive estrogen in women and their periods in women and testosterone in men. So women can lose their periods and the periods can stop. And in men, the testosterone level can drop and the sex drive be diminished and there'll be problems with erections. So those are some of the things when you have too high a prolactin. Of course, the causes of too high a prolactin can either be a tumour making extra prolactin, or you can have a tumour that presses on the pituitary gland, is not making prolactin, but causes the prolactin to go high. And the reason for that is that under normal circumstances, the pituitary is connected by the pituitary stalk to the brain in the hypothalamus. And passing down that stalk is a chemical called dopamine. And the dopamine normally prevents the prolactin from being too high. So if there's pressure on that stalk from another cause, the dopamine levels getting to the pituitary are lower and the prolactin can actually become increased. So that is a cause of a high prolactin level, and that can also present with a high prolactin level, or you can have a tumour actually actively making.
Okay, great. Thank you for that one.
So if you have too little prolactin, then you will not be able to produce milk. That's very, very uncommon indeed, and occasionally happens. So someone earlier was inquiring about Sheehan syndrome. Occasionally what happens with Sheehan syndrome is that the pituitary completely dies, you don't make any prolactin, and then the women can't breastfeed after the pregnancy. But there's very few other causes where you have absolutely no prolactin at all.
Okay, brilliant one there. Okay, so next one. I've been diagnosed with secondary adrenal insufficiency. Is it normal to suffer from fatigue and feeling sick when trying to reduce the dose of prednisolone?
Okay, so the first thing I should say is that most endocrinologists in the UK would use hydrocortisone for secondary adrenal insufficiency. Prednisolone is used. There is a bit of debate about prednisolone. There's a bit of a debate about hydrocortisone. But nevertheless, the dose that people need of either hydrocortisone or prednisolone in this case may vary. People shouldn't feel sick if they're on sufficient doses of any of the glucocorticoids. By glucocorticoid, I mean prednisolone or hydrocortisone. So it's a question here as to why would there be a reduction in prednisolone? Because really, if they're going to be on prednisolone, most people would need around about 3 milligrams of prednisolone in the morning, maybe 4 milligrams of prednisolone. Most people on hydrocortisone need between 10 to 15 milligrams of hydrocortisone. One of the problems we have is that there is no steroid preparation that we can give that mimics what normally happens. What normally happens is you wake up in the morning with high levels of cortisol. If you're a pituitary patient who doesn't have cortisol, you wake up first thing in the morning with very low levels of cortisol, take your tablet, and then the level of cortisol, if you take hydrocortisone, so hydrocortisone and cortisol are the same. Or if you take prednisolone, the levels will then build up. So in terms of the question, I'm not sure why there would have been a higher dose that would then be reduced down again. My guess is perhaps they had an infection, but really it should be the case that when the dose is reduced down to what the normal replacement dose is, you would hope that someone would feel okay, and if they don't feel okay, then that needs to be discussed with their endocrinologist and the endocrinology specialist.
Okay, great, thank you. So can you explain why we have so much pain, muscle weakness and fatigue from Cushing's and on replacement hydrocortisone? I have had both RA, OA, PSA for several years prior Cushing's with bilateral knee replacements, yet struggle with my mobility far more now than I ever did before.
Okay, I think I should probably guess at what some of those abbreviations are. So I'm assuming that RA means rheumatoid arthritis and OA means osteoarthritis. I'm not sure what PSA is. So patients with, so the first thing to say is Cushing's is a really nasty disease. People feel terrible from it. And what I say to patients when they come and when we've formally finished all our diagnostic tests and we're talking about treatments is to illustrate that usually they will feel worse for the first year to 2 years or so before they feel better. And people feel worse is because you're going from a high level of cortisol to a low level of cortisol. Cortisol is very impactful on the way your muscles function, on the way your joints function, ligaments function, and how your brain functions. And usually people feel lousy for that first period of time, certainly for the first year. That's the normal thing to feel. So the question, I guess, here is how long after having had treatment is this particular individual? I would, if it's within the first year or so, then to a certain extent how they're feeling may be anticipated. It's not pleasant at all for them, but at least it is explicable. In terms of will it all get better, most of the aches and pains tend to improve with time. In terms of how the physical changes change, one of the things that improves most quickly is the redness of the face. One of the things that takes longest in the physical function is the muscle strength. It can often take 9 or 12 months for the muscle strength to start returning to normal. By and large, a way of thinking about it is that in Cushing's, it's taken often several years for the diagnosis to be made and come to light. And therefore, it will take several years for the body to try and recover from the ravages of the high levels of cortisol. Cortisol in excess is a really bad thing, and it just takes time. Of course, in this particular individual, they've had other problems as well. So I don't know whether or not, for example, the rheumatoid arthritis is more active again, there's more inflammation going on, and whether that needs to be addressed as well. In terms of the mobility and the pain, that's a common thing. If the questioner had their Cushing's treated many years ago and are on hydrocortisone now in that sense, then I would want to know whether there was another cause for some of the problems.
Okay, great. So we'll move on to the next one. Tests have shown that dosage of desmopressin is correct. So why do my sodium levels keep falling to low 220s and I have symptoms?
Okay, so the sodium level won't be 220. I think it'll be 120, and that's in millimoles per litre. And the question here is, it will depend. So this patient, the person who's inquiring, I'm assuming has diabetes insipidus, and the cause of diabetes insipidus is rather important here, because when, in normal circumstances, when someone is on desmopressin and they have a normal thirst sense, what will happen is that you will regulate the amount of water or fluid you drink such that the sodium will be okay. The only way that the sodium can become low, 120 or so, is if you're on a dose of desmopressin and you end up drinking more than your body needs. And that shouldn't happen if your thirst is okay, because what will happen is as the concentration in the blood is a bit more dilute, that's the low sodium, then it'll switch off your thirst, you won't drink, and therefore your kidney will then get rid of the extra water. So what sort of conditions cause a problem with diabetes insipidus and a problem with thirst? Well, there are things, for example, like craniopharyngioma or other inflammatory conditions like neurosycoidosis or Langerhans histiocytosis. These are other conditions which cause both a problem with diabetes insipidus and with the thirst sense. So the question really is, when your sodium is low, do you actually feel thirsty? And if you do, there's a problem with your first sense. Perhaps you may have had problems I've just described. And if that's the case, then things are a bit more complicated. And that needs a careful discussion, because when we see patients like that, we need to advise them on how much to drink. And it's really governed by measuring body weight, sometimes once or twice a day, and actually making sure the amount of fluid is taken in to maintain that body weight. So desmopressin is usually the dose we would fix to make sure that you don't end up having to get up at night and pass urine during the night. Sometimes people manage very well in this circumstance where they've got a mild change in thirst, where they just have the desmopressin at night and they avoid it during the day. They just pee a bit more during the day. So I think this is something you just sit down and have a discussion with your endocrinologist, and my question to you is whether there's an issue with thirst and what was the cause of the diabetes insipidus.
Brilliant. Okay, so for the next one, slightly longer, I've had 2 transsphenoidal surgeries, June 2009 and January 2015. Brackets, got chemical meningitis. So I spent 4 weeks in hospital trying to balance my DI, then had radiotherapy in 2015. After 18 months, I came off desmopressin, but now feel very bloated and no urge to wee / have an intense urge. Also feel by now I should have more energy. I'm on thyroxine still and 20 milligrams of hydrocortisone daily. Also vitamin D, calcium, ramipril and pravastatin. I feel very fatigued all the time.
Okay, so I'm sorry. The questioner feels very fatigued. They have clearly had a lot going on. I think to have 2 surgeries and have radiotherapy and clearly needing all the pituitary replacement therapy, a lot's been going on. In terms of the tiredness, again, I think this is something where you'd need to have further discussions with your endocrinologist. It is likely that the dose of hydrocortisone is sufficient, but of course, as I mentioned earlier, we can't mimic normal biology in any way perfectly, even with the most complex hydrocortisone regimes, and that can be difficult to do. It's important that you're on sufficient thyroxine, and sometimes patients aren't on enough thyroxine. The usual measure of replacing thyroxine, which is the TSH, the thyroid stimulating hormone that GPs are familiar with, can't be used in pituitary disease. So it's important that you know that your free T4 is sufficiently high when measured to demonstrate that you're on enough thyroxine. In answer to the question about desmopressin, well, desmopressin, if anything, would stop someone from passing urine and can make people feel more bloated and give edema. So I'm not sure. I don't quite understand the issue with the bloating and the no urge to wee. That not being on desmopressin would mean you pass more urine. But I think this sounds complicated. I haven't got an explanation for fatigue, apart from saying that unfortunately, despite everyone's best efforts, some patients with pituitary disease do feel very fatigued. I guess the question is whether there's been a growth hormone assessment, and if that hasn't, that would be a reasonable thing to do, or at least to ask about, because certain people feel much better when they're on growth hormone in addition to the other pituitary replacement therapy. It's not said here whether this is a man or a woman. If it's a man, it'd be important to check whether testosterone is necessary, because that could also impact. So I'm afraid this is one where I can't give a full answer. It's something to sit down and talk through with the pituitary endocrinologist.
Okay, thank you. For the next one, is a low thyroid function related to a pituitary adenoma when no antibodies are shown in a thyroid test?
Okay, so the commonest cause of an underactive thyroid gland is when there is an immune attack on your thyroid. And in that circumstance, you see these things called TPO, or thyroid peroxidase antibodies, are positive in the blood to test. And that will mean that the level of free thyroid hormone will tend to be low, and the thyroid stimulating hormone coming from the pituitary gland will actually be high. And the reason for that is that the thyroid itself is failing, so the production of thyroxine is lower. There's a feedback loop, so the amount of thyroid going back to the pituitary is less, and the pituitary will sense that and try and increase the drive to the thyroid by releasing more thyroid stimulating hormones. So the TSH level is high. And in that circumstance, you then give someone thyroxine, it replaces their body's thyroxine, and you can monitor the dose they need to be on by measuring the TSH level, because what happens that lowers again in response to being on the right dose of thyroxine. This means that if someone has a low free thyroid hormone level in the blood test and the TSH is not elevated, then there could be a pituitary problem. And that's important for that to be considered. And certainly in that circumstance, there won't be any positive antibodies because it's not related to an immune attack. So in summary, if someone has a low free T4 level and the TSH is not elevated, then consideration needs to be to assess the pituitary.
Okay, so the next one. I'm a 61-year-old male and I have hypopituitarism. I've just started with growth hormone. Unfortunately, I keep getting more hot flushes and water retention. Are these side effects?
So these are good questions. There will be side effects if you're on too much or if it's been started too quickly. Not so much the hot flushes, more the water retention. And that really comes down to measurement of the IGF-1 level. So IGF-1 stands for insulin-like growth factor 1. And it would be probably worth you speaking to your endocrine nurse or your consultant to talk about these and see whether you might just need a dose reduction, continue on that dose for a while, and then measure IGF-1 and see, in fact, whether you're one of the people who didn't need very much, because some people get started on a standard dose but actually need much less. So I think that's certainly worth having that discussion.
Right, so for the next one, quite a common question we get, is it normal procedure not to prescribe emergency cortisol injections to patients with secondary adrenal insufficiency?
So at least in our practice in Sheffield, everyone will be who's on hydrocortisone replacement therapy will be advised to have an emergency hydrocortisone emergency pack. That is common practice in many, many centres around the UK.
Okay, so for the next one, I have panhypopituitarism due to empty cellar syndrome. It is said that the pituitary gland is in part replaced by a cyst about the size of a golf ball. Is this diagnosed just by an MRI, and is this accurate? Can this cyst change over time, or will it always be a cyst? And does it grow, and if so, what symptoms might I expect? How often should a further MRI be done?
Okay, so there is a difference between empty cellar and having a cyst occupying the space where the pituitary is. So the real key here is knowing exactly what's going on. If someone has an empty cellar, what that means is the bony cavity where the pituitary normally sits is simply filled by the cerebrospinal fluid, the brain fluid. There's no cyst there, it's simply fluid, which is circulation around the brain. That won't change. If the inquirer has been told they've got a cyst there, that's entirely different. That's not an empty cellar, that's a cyst in the pituitary. And in fact, the easiest way to see that is on a T2 weighted MRI scan. And that will appear as a cystic mass and is quite easy to see on the MRI scan. The MRI scan is fantastically accurate for these things as long as it's been assessed properly. Can the cyst, if there is a cyst, and it's not empty cellar, then yes, the cyst can change over time, and yes, it should be monitored. In terms of the frequency of monitoring, it depends on the history so far, the size and the shape of the cyst. If the cyst is small, then it probably need a scan. I think the first scan's been done recently in around about another year. If the cyst was large and anywhere near the optic chiasm, that's the eye nerve, then you'd need to have a scan probably in about sort of 3 to 6 months to make sure it hadn't changed, or if you developed any visual symptoms. But my guess is that if there's a cyst, it will have to be quite big to have caused hypopituitarism. So I'm a bit unclear here as to exactly what the diagnosis is. In terms of the MRI scan, it depends on what the diagnosis is, the size and the shape, and what the past history is, and when MRI scans have been done before. If we see people who have got a cyst in the pituitary region and it's been stable over a couple of years, then we tend to extend the interval between the scans, but advise patients to contact us if they develop any new symptoms. But the interval between scans will tend to increase if things look stable and there isn't a reason to intervene with the cyst with, for example, pituitary surgery. So I think it's a thing of going back. I don't know whether this individuals have been shown their scans. We usually try and go through the scans as much as we can with patients to show them what their pictures look like. But it's worth knowing whether this really is a cyst or whether this is an empty cellar. They're two different things.
Brilliant, thank you. So for the next one, I have acromegaly, which is in remission. I had an operation on my pituitary gland in June 2012 to remove an adenoma. In September 2012, my hypertension had gone. 2 months later, my blood pressure started rising again, and I was put on blood pressure tablets again. Can you please explain this drop in blood pressure and then the slow rise again?
Okay, so I guess it'll depend a little bit on how old this inquirer is. I'm pleased that the acromegaly appears to be in remission, and pleased that the blood pressure improved. So I would assume in this circumstance that much of the high blood pressure was being driven by the acromegaly, because high levels of growth hormone caused higher blood pressure, and then that was improved. Why it should then increase again, it's a question of whether or not there was an underlying propensity to be developing blood pressure in the first place. I can't explain fully why it was only 2 months. I guess a question is whether immediately after operation there was any transient need to be on other treatments. For example, if someone was hypopituitary and not on so much hydrocortisone, the blood pressure would tend to be a little bit lower, and then of course as things recovered it might increase again. I haven't got a full explanation here. My guess is that if your acromegaly is now in remission, you may have had this just coexisting at a time when you were developing a higher blood pressure. And of course, because you're being monitored carefully, then it would have been documented rather carefully in a shorter period of time, perhaps, than had you not had the acromegaly in the first place.
Okay, brilliant. So for the next one, how much extra hydrocortisone should be taken when competing in high-level sport when you have Addison's disease?
Okay, so there's a good question. There is a good article on the Addison's Disease Self-Help Group website, which I would point you in the direction of. And the answer is it depends on what type of sport is being participated. Often people are asking about sports such as running marathons and things like that, and the advice about that is to be taking extra doses of hydrocortisone before and then during the marathon, between 5 and 10 milligrams of hydrocortisone every 2 to 3 hours or so. But it does depend a little bit on what particular type of sport is being referred to. If someone doesn't need a long duration, so if it's some sort of power sport or a sport where it's not for a very long duration, then there'll be much less need for current doses of hydrocortisone. I point you in the direction of the advice there because it's quite well explained.
So for the next one, what research is there into the unexplained energy problems suffered by myself and many pituitary patients?
So I think we've discussed this above. There is research looking into patients' quality of life. There is research looking into try and optimize patients' replacement therapies as far as possible. There is research looking into the effects of, for example, Cushing's on brain volume and other things. So there are all these types of researches going on. often patients say, well, why isn't more research being done? And the answer to that question is, well, lots of research is being done, but of course, research has to be funded. And some of this research is not perceived by some of the funding bodies to be as important, for example, as funding research work into heart attacks or other problems like that. So there's a lot of endocrinologists, myself included, who spend our lives trying to get money to do research within the pituitary field. Clearly, more needs to be done, but it is the case that there is quite a lot being done and has been done in the past. But nevertheless, I think it's also true to say that with our current issues around how we replace hormones, I think unfortunately people are still going to have problems with energy because whatever we do is never going to be as good as it was when people didn't have a problem with their pituitary.
Great. So for the next one, we've got, I have suffered from core body coldness, not extremities, for years. Tests suggested low cortisol levels. MRI showed a shriveled, half-empty cellar, but hydrocortisone produced ambivalent results. The diagnosis was later reversed and hydrocortisone just stopped. My symptoms remain, but no one seems to know where to look for an answer. Have you come across this before?
Have I come across this before? I'm asked about this type of thing pretty frequently. Many people have a perception of a change in core body temperature. The reality is that actually when this is assessed with careful monitoring, often the core body temperature isn't so variable. But that's not to say people don't perceive it and it can be a real problem for them. Tests for cortisol, well, it depends on what test was done. There are a variety of different tests and they all have their pitfalls with both false positives and false negatives. Mostly, as I said in response to some of the early questions, even when the pituitary looks very small or even an empty cellar, very frequently the pituitary is working normally. The question then is well, what's the cause of your core body coldness you're perceiving? It probably isn't anything to do with the pituitary from what you suggest in this question here. So we do see this. I haven't got an answer for your question. I think it's very difficult. It probably, from what you describe here, probably isn't related to pituitary, assuming that your pituitary has been carefully assessed. Clearly, if someone is lacking in thyroxine, very often they can feel cold and cold temperature, but I would hope and assume that that's been assessed.
Great. So for the next one, do you encounter many cases of hyponatremia in pituitary, and are there any common characteristics in those patients?
Okay, so we see hyponatremia frequently in at the time when patients have operations in the pituitary gland, and we see hyponatremia. I think we addressed some of this in the earlier questions. When there are issues with patients who develop diabetes insipidus, but also have a problem with their thirst sense. So just to recap, in patients who undergo pituitary surgery, they may develop transient diabetes insipidus, but then actually develop a condition whereby there's actually more of the antidiuretic hormone being secreted, and then the sodium level drop, and that's a careful thing that has to be monitored. It usually is not persistent in terms of the hyponatremia. In answer to the question again about hyponatremia in pituitary patients who are on desmopressin, if the sodium level is low, in normal circumstances, so for example, if you took someone who's completely fit and well and you ran fluid into them to drop their sodium levels, you completely switch off thirst, so they wouldn't drink anymore. And by then, what would happen is there'd be no antidiuretic hormone. If you don't have any antidiuretic hormone, you pee out about 300 mils of very dilute urine an hour, which gets rid of all that water, and then that allows the sodium concentration to increase in the blood again. So if you are on desmopressin and the sodium level is dropped, it means there's more water being drunk or fluid being drunk than the body needs. And if you are thirsty at the time the sodium's low, then there's a problem with thirst. And that's, as I mentioned before, something which needs to be asked by an endocrinologist, but also it's something which you need to discuss with your endocrinologist. So yes, balance of sodium is a very real problem for some patients with pituitary disease and needs careful management.
Okay, great. Just to say, we've got about 5 minutes left, just over, so we're going to try and get through a couple more questions. Thank you so much for all the ones you've sent in. We can't take any more, but we're going to try and answer these at a later date. So for the next one, I had a double adrenalectomy in 2005 after unsuccessful pituitary surgery for Cushing's in 2003. In 2014, my ACTH levels shot up into the thousands, now controlled a bit, and I have Nelson syndrome. In January 2017, I had a PET scan showing that inside the cellar there is a predominance of right-sided methionine uptake and an area below the cellar on the right side that shows unexpected methionine uptake, low grade. What does this mean in lay terms?
Okay, so what happens in some patients who have had Cushing's is that you have a tumor in the pituitary gland that makes high levels of ACTH, that's adrenocorticotropic hormone. That hormone drives the adrenal glands to make lots and lots of cortisol, giving the Cushing's. The primary treatment of Cushing's disease, that's from the pituitary, is a pituitary operation. But unfortunately, it's not always successful. And here the inquirer has had surgery for their Cushing's and it wasn't successful in 2003. My guess is that after 2003, they were probably put on some medical tablet treatment, maybe tyrosine or ketoconazole, to try and control the cortisol levels. But ultimately, it was discussed about how to try and fix things. And if you take out the adrenal glands, then you fix the Cushing's altogether because you take out the cortisol. The problem is that the type of tumor that normally causes this, the one you can't treat or is very, very active, can often be the one that can also be behaving in a somewhat more aggressive fashion. And in that circumstance, it can either increase in size or push out more of the ACTH. And that causes this thing called Nelson syndrome. So Nelson was an endocrinologist who described this in around about 1950 or 1952. And this means that there is a tumor and it is a problem because the ACTH levels can cause pigmentation. That can be a problem to patients. It can be a problem if the tumor itself actually gets bigger. My guess is, so this inquirer has been to Cambridge where these methionine PET scans are done. PET stands for positron emission tomography. And what the methionine PET scan is doing is trying to look as to where there is tissue that's actively working to try and identify which part on the scan is actually the area that's causing the tumor and which is the actual bit secreting the ACTH. And so methionine PET scans are only done, as far as I'm aware, in Cambridge. It's still a research tool, and it's trying to be used to identify, for example, which part should be, for example, treated with focused radiotherapy, or if surgery is contemplated, which part should be considered for surgery. I think my guess is that this inquirer may have had pituitary radiotherapy in the past, perhaps fractionated radiotherapy. The question is, could focused radiotherapy be used? So what this is a technique designed to try and identify where active tumor tissue is in contrast to whether there's normal pituitary or perhaps scar tissue. Because on the MRI scan, it's not always easy to see. Sometimes it's very straightforward, but it's not always to see. So I hope that was sufficient in lay terms.
Brilliant, thank you. So might have to make this the last one. So steroids have in part increased my weight and my cholesterol has gone up. However, the side effect of statins is an increase in liver enzymes. Do you have any advice?
Well, if the steroid is being used, for steroid I'm reading hydrocortisone, if that's being given at normal replacement doses, it shouldn't be contributing too much to increase weight. Now, of course, patients will often complain bitterly about increased weight. Sometimes weight has been lost when people develop their pituitary disease because they've had less cortisol and they've lost weight in, if you like, in a bad way. And the weight may increase a little bit, and again, as I've mentioned several times, the way we try and replace hydrocortisone is, I'm afraid, despite our best efforts, far from perfect. So I'm sorry to hear that the weight's increased. If the cholesterol, so the first thing to say is to make sure that you're not on more hydrocortisone than you need. The second thing to say is that some change in the liver enzymes from statins can be tolerated. It depends on how high the levels are. And of course, the other question is to actually question, well, what is the level of cholesterol? Has the statin been started on the basis of a careful cardiovascular risk score? So what happens is GPs and others can access a thing online called a Q risk. In fact, you can access it yourself, which is a Q risk score. And you can put in all your details, and on that it will ask you what your HDL, the high density liver protein cholesterol level is, and the LDL cholesterol, so that's the good and the bad cholesterol. And then it asks you your age, family history, smoking, weight, and other things. And if you put in that, it will give you what's called your Q risk. And most authorities now would not recommend treatment until your Q risk is around about 10%. So it's worth just questioning whether you're, depending on how old you are and what your other problems are, whether you're on or should be on statins in the first place. I think a low level change in the level of liver enzymes can be tolerated, but there are other ways of treating the cholesterol other than statin treatment. So again, that can be discussed with either your GP or with your endocrinologist.
Okay, so I think we're going to have to leave it there for today as our time's run out, but I'm aware that we've still got lots and lots of unanswered questions left. We will hopefully be hosting more of these Q&As in the future because we know they're so popular, and so there'll be loads of opportunities to get your questions answered. Any further questions that were left on the screen here, we're hopefully going to try and pass to our offline support team, and when we post this webinar to view online, we will try and kind of incorporate that via kind of text underneath. So the recording of this session will be made available on our website very shortly. Thank you so much everyone for joining us today, and extra big thank you to John for giving us his valuable time. So thank you, John. I'm sure everyone really appreciates it. I hope most of you have had the opportunity to ask those burning questions that you had. Please remember that in addition to these regular webinars, we have other services as well. So we've got our telephone and email helpline services. We've got our specialist nurse helpline, endocrine nurse, and the next available day to speak to her is actually this Thursday from 9 AM to 1 PM. Her number is 0117 370 317, and she is kind of great for asking all these sorts of questions. We've also recently launched a text service, which you'll get a reply within 24 hours. We've also got a telephone buddies network and local support groups throughout the UK. All of this is on our website, so please have a look. There is a lot out there to help you. And just in other ways for you to support the foundation, we've actually just launched Awareness Month, which will be in October, but we've started everything off now, so you can see how you can help us out. It's all on the website as well. We're always welcoming donations to keep these services going. And if you've got any corporate contacts, we'd love to get in touch with them if you could let us know. And as always, please spread awareness on social media for us. We post stuff every day, so if you can go on there and look and share lots of all our content, that would be great. Yeah, so thank you again to John. I'm sure everyone's really appreciative of all your knowledgeable answers. Thank you everyone, take care and enjoy the rest of your day.